for peer certification standards so that we have a state certification. So we're going to give you a lot of background. We had a number of processes that we engaged in to gather stakeholder input, and Deborah and Lucinda of Inspired at Work will go through that. I'm under a flight path, so forgive any extra noise. So it is my great pleasure to work with Deborah Brasher and Lucinda DeRossi of Inspired at Work, our consultants on this particular project, certification of consumer youth family member and parent or caregivers peer specialists. Turning it over to you.
Okay, thank you, Karen. Good morning, everybody. This is Debbie Brasher, and the other voice you'll soon be hearing on the call is Lucinda DeRossi. And as Karen said, we're with Inspired at Work. And we've been very fortunate to be able to work with all the wonderful people that have been doing the work of advancing peer support and looking at the issue of statewide certification. And that's a lot of great work has happened prior to us being involved, and a lot of you on the phone have been involved in this work. So we thank you all for the interest you have in being here today, and want to share with you the results of the work to date that will culminate in our summit planned for May 17th. We hope that many of you are already planning to be there. And really today is geared towards giving you the best amount of preparation we can so that you're very informed walking in the door about this issue of statewide certification. So let me tell you a little bit about the webinar format in case some of you have not been on this format before. We have several features that we'll be using today. One is called raising hands. This is how you show that you'd like to comment or ask a question. During our presentation, we have 3 time slots set aside for questions and comments. So raising hands would be used during those times. We will unmute you, and then you can ask your question to the group. Everybody will be able to hear. Now, in case something goes awry with hearing you, there are several reasons this can happen, and that we're not able to hear you, then we would ask that you use another feature of the webinar, which is called the question box. You can type in your question there, and whichever one of us is not presenting will be monitoring the questions being asked, and your question will go into the queue along with the people who are being unmuted, and we'll get to your questions as best we can. Now, the other thing about the question box that we'd like to request is that you reserve the question box for the question and answer time period, if at all possible, and along with that, that you limit the use of that to just asking your own questions. We realize that you can see all the other questions, and what can sometimes happen is there's almost a separate discussion going on besides the presentation. And although that sounds really cool, it's actually pretty difficult on our end to do a good job of monitoring questions. So we just ask that you could please use that question box for the question time period only, and then just your questions, if you would. The only other time to use the question box is during the presentation if we say something that you just don't understand, or in order to better participate in the webinar you really need that answer right away, then please do send us a question, and either Lucinda or I will respond to you as soon as possible with that answer. Now, we also have a function called chat. The chat box is used for one reason only, and that is to, if you have technical difficulties, this will get you straight to Karen, who will be able to help you out with any technical difficulties that you have. And finally, well, two more things. We have polling questions. That's a fun aspect of being on a webinar. And we have two polling questions during our presentation, and we'll ask you to respond to those questions and be able to tell you where you stand in relationship to the rest of the attendees on the questions that we ask. So it's kind of a fun additional feature that we'll be using today. Another thing that we would like you to send to Karen is, if you're in a room where one person has registered but there are actually 10 of you present, this is wonderful. We really like that. But we would really appreciate having the names of the other 9 people so that we can accurately represent how many people are on the call today. So that would be the final request from us on our end. So let's take a look at the learning objectives for today. First, we're going to identify the process by which states work with CMS, which is Center for Medi-Caid Services, to develop and define specialty mental health services. And we want to focus on that because in many states it's been tied, certification and billing have been together, and that's been the reason many states have gone forward with this. So we're going to talk about billing and the pros and cons and issues associated with that. Then we have that we're going to articulate the unique role of peer support that peer support plays in the recovery of individuals experiencing severe emotional distress, along with the unique role that peer support plays in the support of parents and family members of a child or adult. One of the things we're going to review are all the data from the stakeholder meetings, and I think they clearly point to the unique role that peer support plays and why it's so important for us to look at issues surrounding certification. And then finally, we are going to, through each section, identify the recommendations that came out of the stakeholder meetings to date for certification and inclusion in the state plan. So we have the first draft of these recommendations. These will go to the summit May 17th for final vetting and input. So let me give you some background about this process for those of you that may be new to this work that's being done. It was actually originally initiated by the California Network of Mental Health Clients in a work group that they called the Peer Support Coalition. This work was transitioned to the collaborative that Karen represents, Working Well Together, and has been, a lot of work has progressed in Working Well Together. The work continues. Some of you may have been involved in the monthly teleconferences that we hold. And the monthly teleconferences have been an excellent way to keep stakeholders engaged in this issue and really get their feedback and input every single step along the way. They have been tremendously supportive and vital to the work products and the recommendations that you see before you today. Earlier work that we did for this project was to develop a research report. Lucinda and I looked at all the states across the country that are currently certifying peer providers. We provide the national data in that research report, as well as having contacted many counties in California about the employment and training practices of peers here. So we have both California and national data in that research report. We then conducted 5 stakeholder meetings throughout the state in which we were getting feedback and input that we'll be reviewing today. There is a final report from those stakeholder meetings. We're drawing most of our information on this webinar today from that report. Both the research report and the final report, by the way, are available on the WWT website. And then our plan is, the webinars are part of the final steps towards our statewide meeting on May 17th to review the recommendations to date, to again bring in stakeholders to look at the issues and create final recommendations that we'll give to the state. One key thing that all this work was based on is the idea of why. Why certification? What's important about it? So one of the reasons for doing this is that it provides formal validation of the role of peer providers. I think that most of us, any of us that have been involved in peer-provided services, know intuitively and instinctively that this is really valuable, the work of peer providers, but the formal validation of certification is one of the benefits of certifying people. It also seeks to standardize the quality of services provided by peers. And it provides information on competencies to employers, as well as a scope of practice that consumers and family members can really benefit from. And one of the things that we noticed and was clear in our research across California is that currently there is tremendous variation in terms of what peers are doing, what competencies are required, and what the scope of practice is. So these issues are a strong reason for certification in and of themselves. And finally, there is the reason for certification that it can be attached to the ability to bill Medi-Cal for services provided. And as I mentioned before, on the national scene, that is a key part of certification, is the ability to bill for services. Now I'm going to turn the mic over to Lucinda, who's going to walk us through this issue of Medi-Cal billing and some of the basic framework around that.
Good morning, everyone. So we wanted to just give you some, like Deb said, some basic sort of big picture information about how Medi-Cal actually gets billed. And this will be really important for people attending the summit because it will affect the kinds of recommendations that we make to the state. So first, every state in the country develops a plan for the provision of all Medi-Caid services, and that people who are considered who have a serious mental illness or an severe emotional disorder, those services provided to those individuals are called specialty mental health services. And states can negotiate with the Centers for Medicaid and Medicare how those services will be provided. They can do that through a number of different options or waivers. What you're looking at here is sort of a very simplified version of how this gets done. So basically, the state plan consists of many, many types of services, but specific to us, we're looking at specialty mental health. Most states in the country use what's called the rehabilitation option to provide their specialty mental health services and have those services reimbursable. We also have, states also have the ability to have waivers. So for example, there's a targeted case management waiver, there's a managed care waiver, which and there are also research and demonstration waivers. All of those waivers are currently being used in California as well as many other states. So right now in California and in many other states, we use the rehabilitation option to provide specialty mental health services, and we also use waivers to provide targeted case management, and it's also how public mental health systems use managed care to provide their services as a billable function. And it's also how counties, different counties within California and states throughout the country use research and demonstration projects. Like, for example, whole health programs may have been funded through a research and demonstration project. The other process that occurs is really an ongoing process, and every few years there's what's called a state plan amendment. And that generally is a process whereby you're making changes to your state plan that allows you to provide services under the specialty mental health plan. One thing that's important to know about California is that California is one of only a handful of states that actually use a county-driven mental health system. Most states use a state system, so that the State Department of Mental Health works directly with the Centers for Medicaid and Medicare to negotiate their plan, and everyone in the state operates under that one plan. In California, the way that it's done is that the state, in this case now the Department of Health Care Services, will be negotiating with the Centers for Medicaid and Medicare to develop the amendments for the state plan. And then each county then contracts with the Department of Health Care Services to provide services within their county. So that's a little bit different than how most of the states operate. And that becomes important when we start talking about making recommendations. Again, most states that use that certify peer support specialists do so through the rehabilitation option, which is the option that California also uses. And it's important to know that the state plan is a negotiation between, as I said before, healthcare services and the State Center for Medicare and Medicaid. Now, obviously, there are lots of groups that have input into that, but they're considered stakeholders. So the actual negotiation goes on between these two governmental bodies. If we're looking at billing for specialty mental health, what we know is that the federal guidelines are purposely broad so that individual states can have a lot of flexibility and innovation within their states in how they provide Medi-Cal or Medi-Caid reimbursable services. One of the things that we do know is that there are up to 35 states that have peer support certifications for individuals that are people with lived experience of a mental health issue. And there are anywhere between, it's a moving target, but there are anywhere between 6 and 8 states that also have either a family partner certification or a parent partner certification. So that's, it's less frequently done, but it definitely exists. I know there is one state looking at a specific transition age youth certification, excuse me, and Georgia has become the first state to have a whole health peer support certification. What we do know that the flexibility that the federal government allows actually means that each state has a unique way in which they provide services, including peer support. So there's not one state that we can use as a boilerplate and say, oh, let's just do it this way, because they're all unique to each individual state. I know that, I just briefly, Linda, we know that you have a question. We're trying to get a hold of you through the chat box and or question box. So if you can get some technical support to deal with that, that would be helpful. So the guidelines from the Centers of Medicare and Medicaid have put out in 2007 a guidelines for how peer support should be presented for approval and what they require to certify peer support services or specialists. They acknowledge that peer support services are an evidence-based model, and the guidelines that they have given to states in terms of submitting requests to have peer support as part of their mental health plan is that there be a plan for who supervises the peer support specialists. Again, using that term broadly to mean all peer support specialists, family, consumer, parent, TAE. The other guideline is that the services provided by peer support must be coordinated with all the other services. So, and this is really an attempt to help the person receiving services not have several care plans all over the place, but know in a coordinated fashion what they're going to be receiving. The third thing is that the state must have a plan for training and credentialing the peer support specialists. And there are our underlines, which I need to be mindful of the animation on our slides, which Deborah has greatly put in and makes them much more interesting. These are the 5 ways that we have seen across the country how people have incorporated peer support services within their state plans. First, you can create a provider type. That would mean you would say that we want to have a provider called a peer support specialist or called a parent partner. And then what happens is services provided by this individual must have their own rate established. So for example, MDs bill at a certain rate, LCSWs bill at a certain rate. This too, this provider type would bill at a certain rate that would need to be negotiated. You can create a distinct service. So in your state plan you would now have a service called peer support, and that service also would be reimbursed at its own rate, which would be, again, a negotiation. Some states have actually utilized their existing service types, most often the rehabilitation option, to allow peer providers to bill for services that already exist within the state plan. So for example, if you are a peer provider, a peer specialist, or a family partner, and you bill a collateral, that service is just simply billed as a collateral and provided by you as either identified as a peer specialist or as just a general mental health practitioner, and that has been already built into the plan, and we'll talk about that a little bit more later. Some states have also used this to develop standalone peer support agencies that provide peer support services as well as other Medi-Caid reimbursable services. In this case, the site itself would be certified and would have to be certified according to the CMS standards, and they then would be able to bill for services. And the last option that we've seen across the country is that peer services are incorporated into the capitated rate within a managed care system, so that it becomes just another service that people can access under the specialty mental health plan that the state utilizes. So CMS, I just want to be sure people understand CMS stands for the Centers for Medicare and Medi-Caid. And there is a federal level CMS, and each state has a state level CMS. So right now, what does California do? California currently uses the rehabilitation option as our specialty mental health to provide our specialty mental health services. We also utilize a targeted case management waiver. So any of you who provided targeted case management, that's being done under a waiver. And we also utilize a managed care waiver where some counties have actually have managed care mental health services within their counties. The state plan currently outlines, and all state plans outline, what is the service type, what are the components within that service type, and who can provide it. So your state plan really lays out the definitions of what the service is, what does that service consist of, and who is eligible to provide that service for reimbursement purposes. In California, there is a category of provider called other qualified provider. And this becomes important when we realize that the other qualified provider is defined as anyone who is 18 years of age and has a high school diploma or equivalent. This is important information for us because it helps us understand a couple of things. Not everyone can provide each component of a service within the state plan. So for example, medication supports. Clearly, MDs provide that service as well as nurse practitioners under the supervision of an MD, but LCSWs don't provide medication support. So it's important to know that people practice within their scope of practice given the guidelines. It's also important to know that county mental health directors do have the discretion to set their own standards that may be higher than what CMS has agreed to as part of the state plan. So while currently in the state plan we have a group of providers called other qualified providers, and they must be, their only qualification is to be 18 years and older and have a high school degree or equivalent, mental health directors do have the discretion to set the standards higher. It's important to know that both the Centers for Medi-Caid and Medicare and the Department of Mental Health, before it became part of the Department of Healthcare Services, that their purpose in including the other qualified provider in the state plan was intended to mean and include peer providers. Typically, the scope of practice for peer providers would be under the rehabilitation services, which falls under the rehabilitation option, and also targeted case management, which is also provided as a waiver to the rehabilitation option. So what we generally see is people with lived experience providing services under rehabilitation services, and those are services like providing supportive assistance to go to school, or supportive assistance to learn how to grocery shop. So it's a lot of skills training and supportive counseling, and also people with lived experience currently provide targeted case management services, which would be considered linkage and referral. So where people with lived experience are billing in those counties where they are billing for Medi-Cal, they are billing to those kinds of codes already. There are some barriers to having peers or people with lived experience, family members, parent partners. There are some barriers to having those people bill Medi-Cal currently within our system. Mental health directors are at risk. Obviously, when they send a bill through the state to the federal government for reimbursement, they have to be very sure that their documentation is very good and can support the bill that they're sending. So there's this concept of risk aversion where mental health directors are risk averse. They're fearful of taking risks because there's a big punishment for not doing billing correctly. There is an acknowledged and sometimes unacknowledged concern about the skill level that peer providers have, and will they be able to document correctly. There's also a lack of awareness that it's currently acceptable under our plan to have people as qualified other qualified providers to bill for Medi-Cal services. Those three things mean that we have very few counties within California actually billing Medi-Caid, or in California it's called Medi-Cal, for mental health services that they're providing. I think there may be only 9 counties in the state that are actually billing Medi-Cal for services provided by peer support specialists. which then leads us to why do we need to concern ourselves with a special peer certification? And these are really the key reasons. One is that it identifies that peer support is a distinct service with its own values, philosophy, and service strategies. So it's going to become important to make the distinction between what is peer support as a distinct service of its own versus what is a person with lived experience of either a mental health challenge or having a child or an adult person who has a mental health challenge as a family member providing services. So those are two different things. And so it becomes important that we identify what is peer support and how is that different than an existing service. The second reason to have peer certification is that the Centers for Medi-Caid and Medicare have identified it as an evidence-based practice. And we also know, looking at the literature, that there is strong evidence that supports the practice of peer-run and peer-operated standalone services, as well as peer support provided within a more traditional setting. Both of those services do have evidence that support their use. So at this point, we're going to ask a polling question, and this is really hopefully to help us get some information about, given what we've talked about, what is your recommendation about how we should support billing? Should we use the existing mental health services code, which means we don't change anything, we just allow peers to bill for a rehabilitation service or a targeted case management service within their scope of practice? Do we create a new peer provider or service codes so that we now say that we want to define peer providers and define the service that they provide? Do we want to allow for standalone peer-operated services? And do we want all of the above? Or answers 2 and 3, which basically exclude using the existing mental health codes. And there's a reason that we need to sort of get that information, and the poll's still going on, and we have only 27 people voted, so please go ahead and vote now. Give your answer now so that we can tabulate the answers. But this will give us really important information to take to the summit so that we could get some clear guidelines about what most people think should be recommended to the state. This becomes a very complicated question, and we'll learn more about that as we go through the webinar. How are we doing on voting? So we've got 75% of you voting. Thank you. So we'll leave this open for a couple more seconds for the rest of you to vote. Okay, so we have 83% of you voting, and we're going to leave that open so that the rest of you can vote. And then we're going to, there are a few questions on the screen that I just want to address while we're waiting, and or comments. And one of the comments is that there is a concern among peer providers themselves that they don't want to bill because it would take away from their time working with the individual. And this is a recognized concern. About 2% of the people throughout the stakeholder meetings didn't want to have peers billing at all. And so that we recognize that that is a concern that people have. And going through the webinar, we're hoping that we can address some of those concerns. But again, all of this information is going to be sort of vetted finally at the statewide summit. So we're going to move now and let you know with 87% of you voting, 38% have chosen all of the above. 36% have said answers 2 and 3. 13% say create new peer provider and service codes, and 11% are saying to use existing mental health service codes, and we have 2% allowing for peer-operated services to bill Medi-Cal. But the largest number is is really interesting, telling us that we have all of the above, a mixture of all of the above and numbers 2 and number 3. So that's an interesting poll result. Thank you very much. So we're going to switch over now and talk about some of the what happened at the meetings. Oh, I think that, no, okay. Sorry, we're going to switch over now, and Deb's going to talk about the stakeholder meetings and some of the results from those meetings. Thank you, and I see that we have some other questions that are coming in, which we'll do our best to answer as quickly as we can. Meanwhile, we're going to just carry on with giving you some background information from the stakeholder meetings that were conducted. We enjoyed very much going to the different parts of California and meeting with stakeholders. We found we actually had 165 people in attendance throughout the state, and we had several ways that we gathered information during the time we spent with the different groups. We had a survey that was given to every participant, and this was a way of collecting kind of objective, more factual information and people weighing in on more on issues that could be done through a survey. We also did focus groups. There were 5 questions that were asked. These are questions that had a little bit more complication to them as issues. They required some more discernment and more conversation to really get at what people thought. We'll share those with you today. We had structured comment periods. This was nice because it was an open-ended place for people to bring up things that we may not have captured in the survey or focus groups, and indeed we got some very good information through those structured comment periods. Here's a look at who attended the groups. So you can see that consumer peer providers were at 48. If you look at family member peer provider, which is 35, and parent peer provider, which is down there at 16, it puts the family member numbers up to like 51, which I think is makes for some good, and I think across the board you can see that we had wide representation and a lot of people interested in these issues throughout the state. Another interesting thing to look at is that many people represented more than one group. We did have people, 42%, that had a single type of representation, but another 29% that were representing 2 groups, as well as you see, more people representing several different kinds of categories of attendees. So first we want to look at, the first question we asked people is, what do you think the purpose of certification would be? And we gave people 3 options. One, that it was to be used for formal validation of peer-provided services. The next option was formal validation as well as billing for Medi-Cal. So that purpose included Medi-Cal billing. And then the third option was maybe there was a group of people across the state who thought certification was not a good idea. So their opportunity to speak up about no certification.
And as you can see, 3/4 of the people that we talked to across the state were in favor of formal validation plus the ability to bill. And there were a group of people that did talk about their concerns about this idea of certification, and we acknowledge that there is also some folks that don't feel like it's a good idea to have peer-provided services certified. When we drilled down some more into the pros and cons, there were many benefits of certification that the focus group participants identified. One is that it legitimizes the role of peers by establishing recognized standards and a code of ethics. This makes it, I think, maybe more easy for colleagues and administrators to really understand and appreciate the function and unique role that peer providers play. There was the hope that it might lead to professional advancement and salary increases. Peer providers are also interested in career ladder opportunities and furthering the kinds of work that they can do in different ways. At least those that would like that really wanted to have the opportunity. There was the thought that it might reduce some of the barriers to coded positions that currently exist, and we're going to talk more about that in a little bit later in the presentation, that many counties struggle with this issue of coded positions. And finally, or another reason, sorry, it will provide peer support workers with a professional voice. So again, that feeling of validation comes through. There was the hope that certification would help to reduce stigma and discrimination in the mental health workforce. There's a felt sense that probably because somewhat of the confusion around role, the confusion around why these new providers are in mental health teams, that there was some stigma and discrimination. And the early people working in the peer-provided services field can attest to getting on board with mental health teams is not often easy. Sometimes it's difficult, and there seems to be residual discrimination and stigma even within our system. So it's going to provide some education to existing staff on the role and value of peer support. And that certification would allow for portability. If you're moving from up northern part of California down to the Bay Area, that your ability to get hired, because you had the certification, employers would really know what your skill set was. Now, also, people mention cautions about certification in connection with billing. So many were worried that it might force peers into a medical model role, and that required language that's more deficit-based and not person-centered. Lucinda and I have done a lot of work across the state on changing that kind of documentation, realizing that recovery and resiliency-oriented language is allowable in Medi-Cal billing documentation, but it's not still across the board a standard thing. So peers are understandably concerned about that kind of language. There's concern that it might lead to the requirement to bill. So one thing that some folks expressed was they hoped there would be the option not to bill. And another concern that it may co-opt peers into system values at the expense of peer values. And this is another caution that's, I think, well founded. Perceived opportunities existed, however. They thought that peer services could actually change the billing language to be much more supportive of resiliency and recovery-oriented work. There was a sense that peer support could possibly result in the creation of an easier process to bill for family members or parents. One of the things that happens is that the child and youth system is focused on the client, well, actually so is the adult system, So all the billing that family partners do in the youth system is in relationship to that child and the child's treatment plan. And the hope is that they could potentially bill directly for supportive services to the parents, and that would get rid of the current way it's doing. The current way billing is being done in for those services now, which is a little cumbersome. Some more opportunities. That peer services, oops, let's see, I already did that one. Excuse me. The other opportunity is that the ability to bill for peer support as well as billing under existing codes when appropriate could be a real advantage and a real positive thing for systems as well as peer-operated services. So now we're going to get much more involved in the discussion of what billing Medi-Cal would involve, and Lucinda is going to take back the reins here and walk you through the stakeholders' input on what billing for Medi-Cal might look like.
Okay, so one of the first things we wanted to do was look at what did the stakeholders at the stakeholder meetings say about what they wanted to do for recommendations to the state. And interestingly, it's very similar to what the your poll results, which we actually can show. If you pull up the poll, we can share those results with you. Push share. I want to share those with you so we can compare them. Okay, I guess we can't do that. Okay.
I mean, they see them.
Okay, so I'm hoping you can see the. You have to hide that. You can see the poll results. Okay. Well, I'm not sure if you can see them or not. It's hard for us to know. But anyway, so during the stakeholder meetings, most people said that they wanted to use the current rehab option, but that they also wanted to certify the provider. 19% wanted to certify the service, and 17% wanted to certify the site. So I think this is really consistent with the poll results, which the majority of people say all of the above. They want to be able to use the existing rehabilitation codes as well as have special certified standalone sites, as well as have a provider defined and the service defined. And we'll see a little bit later how that falls out in terms of is that a risk or an opportunity. The other important piece of information is that when stakeholders were responding to this, if they only chose one of the above, they most often, most people, 55% of the people who responded to this survey when we were at the stakeholder meetings, 55% of them chose a single option. But there were 16% that chose two options, and there were 16% that chose three, and then 13% chose all options. Of the people who chose only one option, the vast majority of them chose to bill under the current rehabilitation services option. 26 wanted to only certify the provider. And there, again, here's your 2% who do not want any Medi-Caid billing to occur. So this, again, is an issue that we are really going to have to look at the summit and get clear about what it is we really want to recommend to the state. And we're going to need to know some opportunities and some barriers of whatever our recommendations might be. It's important to, for the folks that voted to continue to understand that if we continue to use the existing state plan language, the ramification of that is that it allows peer support specialists to bill within their scope of practice currently, which is, again, often rehab services or targeted case management. However, we know that very few counties are actually doing this. And it does not tend to encourage the practice of peer support as a distinct service with its own values and philosophies. So again, at this, we're going to need to be really mindful of what are the intended and unintended consequences of changing the state plan to include all or some of the options, whether it be including it as a service, including it as a provider, or including it as a site. Some of the consequences could be that billing rates for peer services might become different than billing to a rehab service or a case management service, and that could be a disincentive to counties that already bill for rehab services provided by peer specialists. It also, once you enter into negotiations around defining peer support, it could have an unintended outcome of limiting what people with lived experience could actually do. So once you open it up for negotiation, potentially you could have a result that says, well, people with lived experience should only provide peer support. And that certainly could become an unintended consequence that most people, I don't think, would support. So with that new information and with the information that the stakeholders had at the stakeholders meeting, they did develop a set of recommendations, and they wanted to include peer support specialists as a provider type within the state plan, but like all of you said, allow for maximum flexibility in what peer support specialists can bill for. So they wanted it to include peer support as well as rehabilitation services, group rehab, as well as the collaterals that many family partners already do. They also wanted to include plan develop. Specifically, peer providers want to be able to do recovery planning. So planning that may look a little bit different than what is existing currently. They also wanted to make sure that they could still do targeted case management. And they also added that they wanted to be able to do assessments, but they wanted to do assessments that were strength-based. So this is the recommendation from the stakeholder meetings. The second recommendation is that they wanted to include in the state plan an option for peer-operated agencies. I think one of the reasons we see that the response to that looks somewhat low is because there are so very few of them. But certainly the people who are currently operating peer-operated services would like to have the ability to bill Medi-Cal. In addition, they'd like to be able to bill Medi-Cal as a standalone peer-operated service that's providing peer support only. So they don't want to have to also provide medication services, therapy services, and rehabilitation services. They want the option to specialize in peer support only and to be able to bill for that. The third recommendation is that the stakeholders wanted to ask mental health directors to adopt whatever statewide requirements are developed as a consequence of a negotiation between CMS and the Department of Health Care Services, to adopt those standards so that we avoid what happens now is that individual counties can add their own requirements beyond those that are required by the state centers for Medicare and Medi-Caid, so that we have one standard across the state and that the county mental health directors that could honor those. The fourth recommendation was to evaluate the possibility of broadening the definition of service recipient to include parents and family members. And Deb talked about that a little bit. Right now, parent and family partners frequently bill as a collateral service because they're billing under the child's or family member's chart under their treatment plan. They're then billing to a collateral when providing services that are provided to a parent or a family member or a spouse or a child of an adult. Those would be collateral services, so that you're providing information and supports to an individual who is not the client but who is part of the client's treatment plan. And that's most often the case in the situation in children's services. So one of the recommendations is really to evaluate, is there a way of broadening who the service recipient is, particularly in the case of children, so that you can more easily develop and provide supportive services to parents and family members. The fifth recommendation was to address the concern that current practice of documentation may not be aligned with peer support values. And this is really important, not only for peer support, but for many people within the system who are wanting to have a less deficit-based model and a more strengths-based model. And as Deb was saying earlier, we know that this is actually possible, and many counties are engaged in trying to figure out how to do this already. But this is something that our stakeholder group was very concerned about, not just for peers, but for all of the services that are provided within the system. The sixth recommendation wants to develop a policy regarding the importance of maintaining the integrity of peer support. And this is because one of the things that we see happening is that people who have the title of peer support may be drifting into other roles and doing some case management, or even we see people who are hired as peer support doing clerical activities. So it's going to be really important to define what does it mean when we say peer support? What is that? And how do we maintain the integrity of that for the employee? Now, this doesn't mean not to allow people with lived experience to provide other services. Clearly, stakeholders have said they want people with lived experience to be able to provide a wide array of services, not just peer support. But what we're talking about here is peer support specifically, and they want the integrity of peer support to be maintained. We're going to now move into the question and answer period. And what we have 10 minutes for this, and what we'd like you to do is to raise your hand if you would like to speak, and we will unmute you. If you do not wish to speak, please type your question into the question box, and we will verbally respond to your question. So again, we have about 10 minutes for this. Someone's asking, will we be addressing the issue of supervision? Absolutely, we will be addressing that. And so we'll talk, Michael, we'll talk about supervision later on in the conversation. So, if there are any other questions, go ahead and raise your hand now or type it into the question box. The question. Sandra is asking about people who are already certified but not employed as peer specialists. We actually, the stakeholders have made a recommendation about grandfathering in, and we'll talk about that shortly. The next question is about getting into the summit. If you could please put that question in the chat box. We can't really answer those kinds of questions. We want to talk about content here. And Sandra Villegas Plutz, I'm sorry if I'm mispronouncing your name, wants to know about the training for certification, and we're also going to be coming to that shortly. We wanted to give people the opportunity at this question and answer period to talk about or ask questions about billing, Medi-Caid, all of those kinds, and whatever recommendations were made. Looking at Carla's question, would peer support, people providing peer support be held to the same standards of productivity? Then there are issues of pay increases and a career ladder for peer support. We do talk about pay increases and career ladders a little bit later. The issue of productivity is going to definitely become a very important issue, and what does productivity mean in terms of peer support? Right now, very few counties are actually billing for this service, so we do have the opportunity to say, well, since you're not already billing for it, it does represent sort of new, in most counties, new revenue, and what value are we going to place on productivity versus good service delivery, or the amount of time you can spend with somebody that's not billable. And that, again, is going to need to be a question that's really looked at the summit. Darcy's concerned that billing rates for peer support might be less than those that are billed for other professional services. That definitely is a risk. What we've seen across the country is that in some cases they're lower, in some cases they're very comparable. It really depends upon the negotiation that goes on between the Centers for Medicare and Medi-Caid and the Department of Health Care Services. But that is definitely an issue that the stakeholders are concerned about. And Carol is asking about, have peer support specialists aligned their advocacy efforts with community health workers and promotores de salud? And I don't know the answer to that question. So that might be, someone else might know about that, whether advocacy issues regarding the profession of promotores and community health workers, whether they're the same sort of advocacy efforts or if they've joined ranks. I don't know. How are the counties going to financially support any billing for peer partners? I'm not sure that I understand that question. If you could be a little bit more specific, Jennifer, that would be helpful. And Sandra is again asking about, are you wanting to create new codes for billing versus changing the entire structure with billing codes? No, we're talking about what the stakeholders have said would be to add a new service within the state plan that would be called peer support, and it would have its own code. That would not necessarily change the entire structure with billing codes. It would be its own separate code. And Bo-Anna is asking, asking about code of ethics for peer support employees. And peer support does have its own code of ethics regarding relationships with clients. They are different than the relationships that therapists have and the relationships that psychiatrists have, and there's been a lot of work done on that by the work group, and that work will be presented at the summit, and it does follow the sort of best practice recognized standards that most states use, which is that peer support has its own standards regarding relationships with clients that are based upon mutuality and respect. So they are different than typical clinical relationships. So Jennifer is stating that our county contracts only allow certain amounts of money per consumer per episode. How do we manage a billable service with your partners when it would take away from clinician service time? That's a very interesting question, and is specific to the county that you're in. And I'm assuming the people in charge of billing, what they're trying to avoid there is an overmatch, is my guess. And what they would have to figure out is, what's the value of adding peer support? What service would you then take away that peer support would replace? And again, that would be specific to your county, so I don't really know the answer to that. But it's a very good question. Maybe other counties have that issue too, where they are capping how much billable time each client can receive. Ellen, we're going to go ahead and try to open your mic. We're going to unmute you. Are you there, Ellen?
I'm here. Can you hear me?
Yes. Can you go ahead with your question?
Yeah, it's actually more of a concern than a question.
Okay.
By beginning to bill these governmental agencies, won't this give them more control over what we can and can't do, and are we kind of hamstringing ourselves by going here?
Good question. That's regarding specifically the peer-operated standalone agencies?
Well, yeah, but I think any peer agency is going, you know, the minute you don't want to sound subversive, but the minute you allow government in, then you also have to accept what they might require. So it could be standalone peer or a home, but then does that give them so much power that they'll be able to kind of change the way peer support is done?
Right. It's a very good question, one that the stakeholders are very concerned about. And what we have found across the country is that some states have held very faithful to the values and principles of peer support, and for example, used sharing needs definition as peer support. So they have built into their state plans the values and principles, as well as the kinds of services that are provided, so that has become codified. There are other states that are less adherent to those values and principles, although they are still there and still written into their state plans. So right now, peer support, if it is being at all supported by any county entity through billing, is under that county's governmental control to some degree. So the opportunity is to have it codified in a way that supports the values and principles of peer support. The risk, of course, is that once it gets up into the negotiation level between CMS and DHCS, we do lose a little bit of control, and it may or may not end up being pure peer support in terms of values. But that would definitely need to be a negotiation, and stakeholders would be very involved in those negotiations. But your point is well taken. There are always, when there's an opportunity, there's always a risk. What Raven is asking, what fail-safe would be implemented regarding errors in billing, especially in the event of fines? This is a very interesting question, and one of the things that I will say is that for example, in San Mateo County, which has been billing for services provided by peer support and family members, has been doing that for over 14 years and has not had one single audit exception that was a billable service provided by a peer. So we know that peer support employees are not really at greater risk of documenting poorly than any other employee within the mental health system. Documenting for a billable note is complicated, and it's complicated for everybody. And peers, just by virtue of their lived experience, don't do it any less well than any other professional. And so the same fail-safes would exist for peer support specialists, parent partners, family partners, TAE partners, as it would for any other professional. So Carol is just reiterating that It's very important to keep the values and principles of peer support and that you can create a trusting relationship. And the stakeholders have spoken very clearly about that. And further on in the webinar, we will get to some of those recommendations. And I'm going to take a final question. Jennifer is asking about how many directors or county reps are even involved with this discussion. We have been, they are involved with this discussion. We've been in contact with the Mental Health Directors Association. We've also been in contact with the Department of Healthcare Services, as well as OSHPED, which now has control over the workforce education and training monies. And we are really actively seeking their involvement in this conversation. But they are talking about it themselves as well, because they are in the midst of making recommendations regarding a state plan amendment because of healthcare reform. So this question is at the table. And we're going to have to stop now. And if there was a question that you didn't get answered online, we will do that offline directly. And we're going to switch gears now and